Hello everyone, this is Dagum, founder and CEO of Mindstrong. Today's presentation is on transforming mental health. The challenges in mental health arise from the lack of measurement. This translates into challenges in prediction and diagnostic precision. Lack of measurement affects clinical trials, clinical practice, and population health. In clinical trials, measurements are episodic and subjective, collected in a laboratory-type environment that lacks sensitivity and ecologic validity. In clinical practice, on the basis of clinical judgment alone, mental health providers detect deterioration in 20% of their patients who experience increased symptoms of severity. In population health, the lack of early detection leads to late-stage treatments with significant disability and poor outcomes. Similarly, the lack of prediction affects clinical trials, practice, and population health. In clinical trials, it results in poor stratification of risk and precludes trials of disease interception. In clinical practice, it leads to late interventions that are not preemptive and result in modest outcomes. And in population health, care continues to be reactive and not proactive. And lastly, the lack of measurement leads to diagnostic heterogeneity that reduces the effect sizes for interventional trials. Treatment continues to be trial and error without biomarkers that can predict responses or narrow down the selection of treatments. And poor response rates can be attributed to lack of precision medicine. At Mindstrong, we have pioneered digital phenotyping and digital biomarkers for brain health over 5 years of intensive research and development in the California Bay Area. Our starting hypothesis and vision was to leverage smartphones as a tool for global health. The question was, can smartphones solve the measurement challenge and the management challenge? Smartphone subscriptions over the last several years has increased dramatically, and today over 3 billion people globally and growing to 6 billion people in 2020 have a smartphone. We use it all the time, on average 70 daily checks, 2,600 daily touches, and smartphones are more ubiquitous than clean water, indoor plumbing, and stable electricity. Smartphones allow us to leapfrog infrastructure as we start to consider not just mental health as a first world problem, but mental health as a global problem. What is digital phenotyping? It is a new kind of biomarker, one that allows us to digitally measure neurocognitive and neuropsychiatric function passively and objectively, continuously in a patient's own ecological environment. While several approaches have been tried over the years, our initial premise and hypothesis was that the signal would come from the human-computer interaction between a user and their smartphone, as could be measured by keyboard tapping, swiping, and scrolling patterns. Because these events are the way a user normally uses their smartphone, they generate a dense digital signal and data that constitute the raw features. Our processing pipeline, running in the cloud, uses these raw features to create a panel of digital biomarkers daily per participant or per user. And from those digital biomarkers, we are able to extract digital phenotypes that are state-dependent or trait-dependent characteristics of that individual and are measuring state or trait-dependent changes in their neurocognitive and neuropsychiatric function. Now let's take a closer look at how we do this. Our app, running next to the operating system of the phone, captures 45 proprietary patterns that include multiple keystroke or scroll events without actually capturing the content of the keystroke, but dividing the keyboard into different areas from which we can capture patterns and events that are relevant. Each of these event patterns generates a dense time series that can be considered a stochastic process, And to each stochastic process, we apply a set of proprietary algorithmic transformations, 23 in total, to derive a cumulative sum of 1,035 digital biomarkers per user per day. Now let's take a look at these digital biomarkers. This is from one of our early studies in 2013, 2014, where we looked at a group of 40 patients with mild to moderate anxiety, ages 18 to 35. Each one of these patients underwent 4 hours of neuropsychiatric testing by a psychometrician. You see the test battery on the left, including delayed free recall, California verbal learning test, logical memory, all the way to digits forward, digits backward, animal fluency, and fast fluency. On the right, these various tests are color-coded in terms of the cognitive domain that they represent. What you see here is the clusters of digital biomarkers from the keyboard behavior and their loading on the various gold standard neuropsychological measures. Transitioning to more recent studies, what we're going to show in the next several slides is how these biomarkers can correlate and track changes in cognition, changes in mood, and neural correlates as measured by functional MRI. These next few slides are from a study done at Stanford University from a large NIH grant in the Department of Psychiatry. The study involved 100 patients, 18 to 65-year-olds with major depression, and went on to measure cognitive and emotional function, as well as functional MRI and symptom severity. We examined each biomarker's psychometric properties, neural correlates, and clinical constructs in this study. Shown here are the biomarkers' sensitivity and specificity to psychometric measures, including impulsivity, executive function, attention, and working memory. Different biomarkers correlated with different measures and showed a high degree of specificity. Next, we looked at the neural correlates as seen in functional MRI. Shown here are 2 biomarkers measuring task switching and impulsivity, and attention and concentration. The 2 neural circuits being examined were the cognitive control and the reward neural circuit. Below, you see the various Brodmann areas for each of those circuits, and then you see the different biomarkers loading on the distinct Brodmann areas. Finally, looking at how well these biomarkers track clinical ratings for mood, what we see here is the PHQ-9, and what's shown are the digital biomarker loadings on each of the PHQ-9 items. For each item, we show the best biomarker in the square, in the light blue square, and its best signature shown in the darker blue triangle. This best signature is computed using a very advanced and powerful technique called Supervised Kernel Pca, which allows us to take the very large high-dimensional space of biomarkers and identify the ones that are most relevant for a particular lower-level item, construct like anhedonia, and construct a improved prediction leveraging the various biomarkers that load on that construct. What's important to note here is that our biomarkers aren't directly measuring many of these constructs like insomnia, but rather what they're measuring is the consequence of insomnia. In other words, our biomarkers are very sensitive to changes in neural function and cognitive function, as can be seen by changes in insomnia, mood, or anhedonia, and the effect that those can have on the various cognitive functions by domain. Let's take a closer look at how we can measure cognition and predict cognition. Here we're looking at one of our earlier studies, and these were patients who underwent that 4-hour neuropsychometric battery. And what we're looking at now are their actual test scores showing the mean and the range, and the correlation of the biomarker predictions using the powerful Supervised Kernel Pca for each one of these test scores against the actual test values that were reported by the psychometrician for each patient. Many of the correlations of these predictions are in the 80%, which is notable because this is typically the test-retest reliability of these tests themselves. In other words, our predictions are as good as the test-retest variability of these tests. The last few slides have shown the validity of these digital biomarkers at predicting the results of gold standard neurocognitive neuropsychiatric tests. What's important to note is that these predictions are based on a single day's of data that is required to generate the digital biomarkers. But we are generating that data daily, which opens up a new view into continuous brain function assessment. In other words, our novel IP using the human-computer interface has now created, for the first time, an objective and specific and continuous measurement of human cognition, mood, and central nervous system function. This gives us real-time visibility into how the brain is performing and allows us to deliver interventions to optimize performance and treat disorders before they progress. Let's take a look at some of the real-time components and how this looks longitudinally going back to one of our early studies. Shown here are two biomarkers, a blue biomarker and a red biomarker. The blue biomarker correlates with memory, the California Verbal Learning Test, and the red biomarker correlates with executive function, or the TRAIL-B test. What we've done here is we've taken a population of 40 patients with mild to moderate depression or anxiety and taken 30 days of biomarker measurements and sorted the biomarker measurement from best to worst for each individual. In other words, everyone's best day is now sorted to day 0, and everyone's worst day is sorted to day 29. It's important to note that everyone's best day occurs on a different day of that month, as does everyone's worst day. But what's important is when we sort the biomarker measurements this way, what we see is that the best correlation with the test, whether it's the California Verbal Learning Test for the blue biomarker or the TRAIL-B test for the red biomarker, occurs on their best day. And then we see a gentle drop in the correlation with a plateau, and then we see a further drop in the correlation as we get to their worst day. This property is highly conserved across all biomarkers loading on all psychometric tests and now across multiple repeated studies. And what it taught us was that when a person comes in and is tested, they're being tested in a very controlled environment. And they're being tested by a psychometrician who is trained to get the best measurement out of them. And the tests are abstract and not evoking any emotion. But when they walk out into the real world, and if they're suffering from a mental health disorder like depression or anxiety or schizophrenia, their interaction with the real world and their performance, their ecological performance in the real world as they're being challenged by their mental health disorder or challenged by the lack of adherence to medication or the lack of sleep or job stress or family stress, their profile now begins to look very differently. This is very powerful now because this gives us, for the first time, visibility into an individual's daily function in their environment and allows us to construct a clinical care model that is anchored on a patient's performance, which enables us to intervene as a patient starts to relapse early before they're seen in the emergency department much too late. This gets to the challenges that we discussed earlier in mental health, which is measurement-based, the ability to have a window of measurement into a patient's functioning in their environment that now enables both prognosis and prediction, early detection, and preemptive care. Now let's take another look at a similar result. This is from one of our own studies using ketamine to treat patients with treatment-resistant major depression. What we see here is a small cohort of patients being treated and measured periodically using whether it's the HAM-D for depression or the SHAPS for anhedonia. Each data point represents one patient day measurement, and the various data points are concatenated into the 60 data point time series for the HAM-D and for the SHAPS. In orange, what you see is the best digital signature that tracks the HAM-D measurement or the SHAPS measurement, where each data point here represents a measurement or a prediction for that patient, for that HAM-D score of depression or for that SHAPS score of anhedonia across the cohort of patients across time. Again, we see that the digital biomarkers give us a continuous daily insight into a patient's performance in their ecological environment that is validated against the clinical ratings delivered here by our psychometrician in this patient population. What's exciting, of course, as we mentioned earlier, is that all the measurements are being made based on a user's passive interaction with their smartphone, which gives us an early indicator of health with global scale. The temporal variability in digital biomarkers signal the onset of brain pathology that is attributable to a disorder relapse. In mental health, early detection and management is critical and is able to reduce relapse and hospitalization by up to 50%. Now let's take a closer look at risk prediction for patients that are potentially deteriorating. Shown here is the 18 to 35-year-old cohort with depression and anxiety. What we're seeing now is the participants numbered 0 to 29, the various psychometric tests that were done by a psychometrician on the left, and 30 days of data where we're looking at now the variability in the digital measure of that test for that patient, with a heat score showing high variability in the red and low stable lack of variability in dark blue. What we're seeing here is the patient population that exhibits the highest variability over those 30 days, where the high variability is an attribute of risk of relapse in that patient. And as clinicians, if we were to receive this daily report of the patients that we're following or care for, I think we would all know which are the patients that we would now pick up the phone and call to assess how they're doing. To summarize, Mindstrong is an R&D patient care and population health platform. We support diagnosis and treatment across all three with various different products, including companion diagnostic for drug R&D, companion therapeutic for patient care, and risk prediction for population health. We have numerous drug trials, registration trials under study, working with some of the world's largest drug companies focused on CNS drug development. We have various provider pilots working with some of the world's largest healthcare insurance, and we have several very high-profile population studies addressing mental health disorders. We have a very robust patent portfolio with 5 issued patents. No other ecologically massively scalable biomarker exists, to our knowledge, for brain health, and we're uniquely positioned to transform neuropsychiatric and neurodegenerative healthcare. We are building a Fortune 100 brain health company with numerous partnerships with healthcare systems, payers, and drug companies. We feel that CNS digital phenotyping will transform all healthcare sectors, and we will continue to partner across all these sectors. With payers, it will provide early and accurate signals of relapse, remission, and efficacy of treatment to reduce costs. To providers, it is a measurement-based brain health for accurate clinical assessment, efficient resource utilization, and improved patient outcomes. And for pharma, it enables stratification of neuropsychiatric and neurodegenerative disorders. These biomarkers are based on CNS trials to measure drug intervention, efficacy, and CNS toxicity. We have a very robust partnership R&D pipeline that covers the various healthcare sectors, including payer, provider, pharma, and multiple clinical studies with some of the world's top academic and government-funded institutions. Our clinical studies and partnership studies cover both neuropsychiatric and neurodegenerative disorders, including major depression, schizophrenia, bipolar disorders, post-traumatic stress disorders, ADHD, Alzheimer's, Parkinson's disease, and several other neurodegenerative disorders not shown here. Our clinical vision is one of collaborative care management, where we will pioneer a new model of outpatient behavioral care. This model is founded on passive, ecologic, objective measures of brain health. And begins with the Mindstrong app and the passive digital biomarkers that allow us to assess a patient's emotion, behavior, and cognition, all in a patient's ecological daily environment that creates an early signal or a window of insight into how a patient is functioning as an outpatient in their environment. For the first time, medical providers, social workers, medical professionals will be able to identify patients preemptively and care for them proactively as outpatients and not reactively when they show up to the emergency department for readmission. The Mindstrong solution improves patient access, reach, and quality of care. It enables early diagnosis and intervention, provider productivity, and telehealth consultation for early management. It empowers physicians and psychiatrists with objective measurements that are passive, continuous, and ecological, allowing psychiatrists to care for these patients in a new model of mental health. Thank you.